Zoom says.
I'm going to start the recording. All right, so thank you guys all for coming to the second part of our little series on rib fractures. Last month, we heard from Dr. Hoofnagel about the surgical approach. Today, we have our special guest, Holger Baumann from the Department of Anesthesiology. He splits his time with us, and we see him about half the year. In the rest of the time, he spends in Amsterdam. So what's nice is we have a little bit of a different perspective. We don't have just a WashU perspective on this, but he's going to be talking to us today about pain management and rib fractures. And with that, Holger, the floor is yours.
Thank you. I just closed the door. Yeah, thanks for inviting me. It's a short introduction. First, housekeeping. If you want, you can send me an email and I can send you a PDF version of the talk. This would have the advantage, in contrast to the video, that you can click on the links and you come automatically to the articles. The story for me with rib fracture management restarted in Amsterdam about 24 months ago. And a lot of problems I encounter here while preparing for this talk. So I hope I can give some insights. The goals of my presentation is to share something actionable that we can really change and move forward, hopefully. I would like to give an update on regional anesthesia for rib fractures, the lessons we've learned in Amsterdam, and I would like to give a look into the future. How could it look alike? So this is a copy of part of the email we get every day if you're interested in trauma. And just the interesting thing, so when I read it, rib fractures, incentive spirometry, bad, weak cuff, rib score 5, incentive spirometry every hour, pain, consult in unit, and spinal precautions. I thought, wow, what does that mean for the praxis? What are we really doing? So I tried and started with finding the rib fracture protocol advance. And everything I tell you is just what I find or couldn't find, and correct me if I'm wrong. So the rib fracture protocol at BGH is based on a score with risk factors. And if you have more than 3 points, you should go to the CQ and to consult to the acute pain service for an epidural is written. And there is, if you're a little bit better, you go to the OU. So I couldn't find anything else in the ED from the acute pain service or in the ICU on the protocol on how we manage these patients. And I think it's very important to have a comprehensive protocol. And that's the reason I would like to call with this talk for the update of our protocol and really work on a comprehensive protocol for BGHs. Just a little going back. So what are outcome data after rib fractures? 10 to 15% of severe trauma have chest trauma. And if you look at the mortality, it's obviously depending on the age, but it's about 6 to 10% or 11. And especially on the other side, what I find interesting is the long-term sequelae of rib fractures. So only 60% of the people have a functional reduction and only 70% return to work. So I think the first step, that is also what we did in the protocol here, is to get the patients at risk. And I like personally this chest score. There are a lot on the internet if you look it up. Really good, like it because it's validated and it makes sense and it shows you what it's all about. So you start with risk factors. The scores are a little different from what we use here, but with a higher range of score, you have a higher probability of complications. And this should lead to where do we place our patient, where is the admission place, and what do we treat, and how do we treat it? And this is a rib fracture tool from the UK. And they have, at the beginning, I hope you can see this when I come with my mouse, a score from 1 to 10, 11 to 30, and greater than 30. And this means a different way on admission, a different way of treating the patient or the pain of the patient. And I find it very helpful. So what you can see here, they start with what most European chest bundles do. They start with non-opioids, then opioids, and then regional anesthesia. This is all stratified on the risk. And you see on the right lower side also patients who most likely will benefit from that. If you ask you why regional and why should we have a multidisciplinary protocol, I think there are pretty good data and reviews that shows that you have less delirium if you can prevent using opioids, or if you use it not that much. It lowers mortality, and rib fracture pathway shows to lower the ICU utilization and complication and the length of stay. What you find in general during the whole lecture here is that the literature is relatively new. So I prepared this 1.5 years ago, and quite a lot changed since then, and we got new data. So here I was very surprised to find this, but this is as data from this year, where they, I think it was Vanderbilt, implemented an acute pain consult, and they showed improved mortality, so less people died. I found this very odd that only the acute pain consult is doing that. But on the second slide, you see that the rate of epidurals was rising to 42% of all patients they saw. But one of my main topics for this part of the talk is the use of non-opioids improved dramatically, or went higher. So NSAIDs went up from 33% to 55%, and gabapentin from 28 to 51. I think this is a very interesting approach. I'm not sure if this is a causality, but I think it shows what the involvement of an acute pain service, besides the question place an epidural, can offer some advantages. And from the same year in a trauma journal, there is a hospital where they had a pre-post-court study, and they implemented a multimodal pain regime where now non-opioids are the first-line agents. And the opioid consumption in 5 days and prescribed at discharge fell with 30%. I found this really a very interesting number. And I will show you, or try to show numbers how we do advance later. The same journal, and they, in this hospital from Tucson, Arizona, they prospectively validated a rib fracture guideline. So they also start with a score calculator, and from that they group the patients. Sorry, and RIG 1 means if possible discharge, RIG 2 goes to the floor, and the rest goes to the ICU. Sorry, and what they found out, that no patient of the RIG 1 group was readmitted, no patient of the RIG 2 group was unplanned admitted to the ICU due to rib fractures, and the implementation of this system itself shortens the ICU and hospital length of stay with the same mortality. I found this very interesting, and this is what I think is the basis for my call for a comprehensive protocol. And I would like to ask you if you have questions right now.
So nothing in the chat right now.
That's fine. I just wanted to give the chance to ask about the studies or anything else. So my slide then is an update is needed. We need risk assessment, stratify admission and pain management, and we should try to standardize pain management, more involvement of non-opioids, regional anesthesia, and what I will show you later, I think we need high quality data of what we are doing for QI projects and for benchmarking. The next part of is what can regional anesthesia add to what we do right now. If you see, these are all reviews in journals about cardiothoracic surgery and CT trauma, and that we have now reviews where you have regional anesthesia and cardiac anesthesia, you see that something happened, and this wasn't applicable only 3 or 4 years ago. What we usually do for rib fractures is thoracic epidural and probably a thoracic paravertebral block. But I want to talk about some relative new blocks. It's erectospina of ESP block or the serratus plane block. I expect that we have not only anesthesia people watching or joining us, but also from the ED and ICU and trauma. So I want to explain what fascial plane blocks are. As you can see here, these little blue lakes, these are all options where we can do fascial plane blocks. Fascial plane block means you inject the local anesthetic not close to a nerve, but between two muscles where nerves running, or between a bone and a muscle. In general, all these blocks are ultrasound guided. They are volume dependent blocks, and the bolus works best. In general, they have a much better safety profile because they are superficial, and anticoagulation or coagulation issues are not that important. Just to give you an impression how this looks like, this is a video from Amit Pava from London, and I couldn't make it better, so I copy and paste it from YouTube. You see the nerve between the three muscle layers, and the needle is coming, you inject, the two muscles go out, and then the local anesthetic spreads. This is what you use, probably most people use for when they do a tap. But this can go further, so you can flow from plane 1 to plane 2. And what you see here is in the graphics is the situation for the intercostal nerves. Due to a diffusion gradient, it can go through layers of tissue to the nerves. And this makes these new blocks possible and I think valuable alternative. If you look here, the chest, you see that the erectospinal block is done from the back. It's the same setup as you would have for an epidural, but the serratus anterior plane block has the advantage you can do it in supine or lateral position. You don't even have to move the patient. I will show you more details over the blocks now. So the ESP, and this really, I think it's a little bit of funny. This is a video from 2019, and the mode of action, why does it work at all, is with a question mark. And the idea was, without any proof or big proofs at the time, you inject the local anesthetic at the transverse process, you get the dorsal ramus, probably it goes to the ventral ramus, you get a paravertebral block, probably sympathetic, but nobody really knew besides it's working. Last year, we got a very interesting 3D micro CT study, and in spot A, you see the old idea of how it is, and that there's a barrier for the local anesthetic to go further. In this study, they could see that this is different. There are two slits where the nerves and the local anesthetic can move. You see it also on the right side here. There's a medial and lateral slit. And over this, the idea is that there, the local anesthetic can flow. That means that from the transverse process, due to a diffusion gradient, the local anesthetic can go to the nerves you really need to anesthetize the chest. Just some 2 slides about the ESP. This is how we do it here for elective surgery. Sitting, you could do it in prone or lying. You can discuss what is possible if somebody has really rib fractures and is in pain. And on the right side, you see the needle coming from the right and the transverse process, the white line. And while they injecting, you see hopefully that the muscle is rising up from the transverse process. And that means that the local anesthetic is spreading and then anesthetize the nerves. The same, obviously, you can use a catheter, and this is the transverse process, and you see the catheter when you inject. I'll just show it again. It's rising up, and with that, you can anesthetize for as long as you want. The other block, serratus plane block, it blocks usually, you see now the graphic where it blocks and where the ultrasound probe is placed. It blocks a lateral cutaneous nerve of the intercostal nerves, can be done supinal lateral, has an excellent safety profile. You can place a catheter very easily, and as most blocks with this area, it works best with a bolus. Here again, a video of a single shot. You see the rib, you see the pleura. And while you inject, you see, oh, we have to get a little deeper. And now you see the flow of the local anesthetics, the black line, right and left. And I'm not sure. Okay, we had that. Here you see the same with the catheter in place. And you see also that the lung is not at the correct space. So it's a pneumothorax in this patient. And with this catheter, we could get the patient pain-free. And the next slide shows you how we did it. So the patient suffered from several injuries, and we did this serratus plain block on the left side. Because the patient is usually comfortable, you don't need any sedation, and you can do the block in the way the patient is coming. And you see that you just inject and the local anesthetic goes in. I can talk to the patient and ask her how she's feeling, if the pain is getting better. No, I'm doing fine. And it's all good, and go on. You place a catheter and the patient is happy. That's obviously the way you want it. The question was always why, or is always, why does it work at all? Because you only anesthetize the lateral cutaneous branch, and you don't really get to the intercostal nerve or to the pleura. And there's a study, that's again, where they found that if the fascias are intact, you don't stain the intercostal nerves or the ribs. But on the left side, where the ribs are broken, they are stained. So the idea is to say, with the disruption of the planes, the local anesthetic gets more options to flow and can achieve the anesthetics we really want to achieve. And I can tell you from my experience, we do this now in Amsterdam for years, it works great. But what is the evidence? As you can see in this slide also from Amit Pava, and he did it in 2017, we have a rise in fascial plain blocks. So the blue one is a serratus plain block, and the green one is a ESP. And as always, if something is new and the literature is coming up, it's usually case reports, case series, retrospective, so not really high quality. And I don't want to go with you through every paper that's published, but I want to make a point, and I hope I can do it if I give you a selection of articles. So in this article or a recommendation, the prospect group, it's a group of anesthesiologists and surgeons who come together and try to make evidence-based solution for pain problems. They come up with something for VETs, and I think it's transferable enough. So the three main conclusions from this paper is the perivertebral block is in favor compared to a thoracic epidural because it has less side effect and it's effective in the same way. The ESP is named an alternative and is non-inferior to a perivertebral block. And so serratus plain block can be used as a second choice. I was surprised. And then I found that in the editorial of the same journal, they questioned that already, and that probably it's not true, probably it's the first choice. But what do we have real life data to prove that? This is a study from 2019 where they have in the UK a consecutive audit of 350 patients. And you can see on the right side that the incentive spirometry as a marker, as a physiological response to pain management is better regardless if you do a serratus plain block, a perivertebral, or a TEA, or thoracic epidural. If you see the pre-block combination, it's almost the same. So 80% have severe pain, 25% have moderate pain, And in the post-op, you have the same result everywhere, almost no severe pain anymore, and it's going down at least 1 grade. So I would conclude that, especially if an epidural is not possible, the serratus plain block is a valuable alternative. And I found this study also from this year, where it's a small study with 70 patients per group, but they started that as a pilot study, and they couldn't find any difference in a paravertebral block and an ESP block for rib fractures. That means if we say that there also is no difference or not a clinical significant difference between a thoracic epidural and this erector spinae block. Also this year, it's a prospective randomized trial with 50 patients where they gave every patient a sham block and a real block. So it's the ESP versus the serratus plain block. And as you can see, the pain effect was almost the same in both. All the patients got 2 blocks, 1 sham block and 1 the real one. And if you ask yourself, why is the pain rising on the right side after 12, 16 hours, it's because they did single shot. Usually the goal is to have a catheter, and then you can prevent this rising pain again. So I found this very convincing, and I would share now data we have from Amsterdam. And so in the first 8 months, we had 64 patients, 93% got a catheter, regardless that 20% were on anticoagulants. And I will show you the flow chart later. So you see how many epidurals and ESPs we did. The epidural failure rate was 21%. I'm not sure if this feels a lot or not for you. This is completely in the literature. And epidural failure is everything from you can't do it, you have secondary catheter migration, or it's just not working good enough. The ESP failure rate is almost always a bad taping of the catheter. So we had to learn to deal with that. And now the failure rate is much, much lower. We just didn't do a good job, but that's the reason you learn. And all the data we couldn't get out of EPIC retrospectively, and we just get them prospectively, so I can really vouch for this data. What else changed is that we now have bolus pumps. We don't have continuous pumps anymore when using these blocks, and we use, in general, in the ED, much more chest TTs, because we had patients where we just missed the pathologies of rib fractures. And we could achieve that we have an acute pain service consult in 60 minutes. Also, I thought, okay, sounds great. Let's see what Barnes-Jewish Hospital can do. And I tried to get data. And I've encountered the same problems I had in Amsterdam. The data I get are not conclusive. It's really sad. So from the trauma service, I got the rib fracture numbers, anesthesia consult, and epidurals. So that means that in general, 45% of the patients get an epidural. And I would have expected much more patients, what I see when I check the daily trauma patients. And then I asked a colleague who has a capacity to do that, can you do an EPIC search about rib fracture and admission between this time frame you see? And he could only find 138. This is by far not correct. So I thought, can I show the data at all? And I think it shows one thing. First, we have to get better data. We have to get better in documenting. Otherwise, we will never see how good we are, how bad we are, and where we improve. On the other hand, if these numbers are just a little bit how it really is, I found it very interesting, and I want to discuss this probably later. Why are we not using more non-opioids? 20% get NSAIDs in this group, gabapentin the half at least, and lidopatch as a surrogate if no epidural is possible, together 37%. I think it's a marker that we don't use everything we have. Probably the patients are doing great and we don't need it, but I doubt it. Now I want to show you how we do this, or started this in Amsterdam. So we started with assessing the risk factors. I will show you how we defined that. You call the acute pain service, and then there's an assessment if local regional is possible from a technical point of view and time-wise. If it's not possible, we start a morphine, ketamine, or lidocaine, reassess the patient, and try to do the block the next possible time. And the fine print for that is that we have risk factors defined to make it as easy as possible. My primary goal was to have a calculator in Epic, but that was also complex and I just wanted to start. So these were our risk factors. What we changed also is that we really assess the pain on deep inspiration and or coughing. At the beginning, we found sentence in Amsterdam like, pain is tolerable if not breathing deep. So we don't have that anymore. We really have to train, or we train the people. The step 2 is always local regional or IV analgesia, and if it's not possible, ketamine. The IV analgesia is meant opioids. We daily assess the patient, and we always check also, that's point 4, that if it's no local region technique, if it's needed, and if it can be done now. This could be the situation that you say, I don't have time at 3 a.m., but probably 8 a.m. is a good time to do something. The strategy, and of course, catheters are preferred, is relatively easy. If the patient is going to the trauma unit, we make a pit stop at the PACU and do everything we need to do. And then the patient goes to the trauma unit or the ICU. We usually go to the ICU. Coming back to the step 1, as in most hospitals in Europe, are non-opioids, and then opioids if needed. I think that's one of the big differences. If you now conclude the what do we have? And we have in Amsterdam the epidural, paravertebral, because that's the same contraindications. And the weakness is obviously you can't do it if somebody is on anticoagulation. At least in Amsterdam, it was in 20% of the patients. Sometimes it's technically challenged in older patients, but on the other hand, one catheter and you can work on bilateral rib fractures. The erector spinae block has much less side effects, so there is no hypotension. It can be done also sitting lateral prone and can be done in anticoagulated patients. This is a study from 2021 where they did a report about 300 blocks in anticoagulated patients. It's a US study, and they didn't have any problem. The serratus plane block has the huge advantage of being done in supine or lateral position. And there is, from my perspective, not a single concern in anticoagulated patients. In Amsterdam, we do it also often if we don't want to turn the patient or the patient is ventilated in the ICU and is to be weaned. We just do a serratus plane block on the side of the rib fractures, and the patient usually is much easier weanable from ventilation. If that's all not possible, we give IV ketamine and lidocaine. It helps, especially the IV lidocaine. If you look into the literature, I'm not really convinced that it's better than a block, but it's for sure better than nothing. Are any questions about that?
I have a question about a lidocaine infusion. Do you often see changes in hemodynamics with that?
No, it depends on what you see. I think it depends also from the rest of the injuries and the treatment you give. Usually the IV lidocaine doesn't bring any problems. We use, in Amsterdam, we use IV lidocaine a lot as a surrogate for an epidural, especially for intra-abdominal surgery, and we don't have an additional problem with that. At least for sure not in terms of blood pressure if you compare it to an epidural. And I just looked up the chat, and Doug Schur said ortho and head injuries don't like NSAIDs. That's fine. But I think we have to come to a conclusion. What are contraindications? And if you look in the literature, there is no reason not to give NSAIDs for some days at least. And as you could see in the papers I mentioned earlier, other hospitals do that, and they don't report any problems. It's very common in Europe to do that. So probably we should all refine our feelings and go back to data. I understand, and that, Doug, I have to say, yes, that's the way it is. Not everybody has just rep fractures, but I think it would be a change of culture to say, hey, we give non-opioids until we can't give. I think this would be a game changer for Barnes, from my perspective. Are there any other questions? Then I would come to one of my favorites, that's the future. And wait a second. It's cryoneurolysis, in my opinion, and it's cool. If you can see, in the last 2 years, there were 3 reviews about the use of cryoneurolysis in chest pain or after rib fractures. And I would like to show you what this could be. And some weeks ago, we had a handheld device here we could at least see. And I would like to implement or to introduce you to this system. First, cryoneurolysis. It's obviously you treat with cold, and it's about the 2nd degree in this 5-degree classification. It means that you have a Valerian degeneration, but endo, peri, and epineurium are intact. So you have to be between -20 Celsius and 100. And if you compare this to other neurolytics, you see it's really the only one that's doing cold. Pulsed RF and cooled RF, still hot. It's a completely different thing. And how does it look like? So here you can see the ice ball, how they call it. So this is where the cold exists. The axon is damaged. The epineurium is intact. And the regrowth of the epineurium goes on the highway that's still there. And that consists for the duration of action from 8 to 12 weeks. And I think this for a one-time treatment is a great achievement. But how does it look like? Do we have evidence for doing that for that in rib fractures? So the best evidence is for cryoneurolysis in pectus excavatum surgeries. And there are 2 prospective studies, and they both show the same. So you have less morphine equivalence, and the patients are sent home earlier. If you combine all the retrospective studies, you come about a patient number of 500. They all show the same result. A month ago, there was, I think, a great study published in anesthesiology. It's about patients' treatment following mastectomy, but they did cryoneurolysis in one group, and the other didn't get it, but the other group got a sham block. And they did everything the same. And what they found out that they had a 98% reduction in opioid usage in the first 3 weeks, no oral opioids in the first 12 months, and less chronic pain after 1 year. In this study, you could use more patients. Probably you want to do this in rib fractures, but I found this a very good study and encouraging. But what is cryoanalgesia and how does it work at all? So in general, you have 3 techniques: the open, during a VATS, a percutaneous. So this is a study from 2020 where they used open cryo in open repairs of TAAs, and they could show a significant reduction in narcotic usage with that. And I want to show you how this works, and they published a video for that. So you see the ribs, and this is a machine where they apply the cold. You see the change around it. it's a little vapor coming up, and it's getting really cold. You see this? And then now you see the freeze, and then they defreeze it, and you go to the next rib. This way you work your way down or up, and you do the cryoneurolysis. Oh, that's double. This is an image I did with the iPhone from Amsterdam. It's about cryoneurolysis in pectoris excavatum surgery. You see the ribs, and you see during the thoracoscopy, they just go freeze. The freezing cycle is usually a minute and a half, and then you have to defreeze for 30 seconds, and then you move on. The third, and obviously for anesthesia, the most interesting part is percutaneous cryoneurolysis. I don't have such great videos, but I think it will show what it's all about. On the left side, you see the two ribs and the needle coming from the left side. This pleura sliding that you miss is correct, but this is a cadaver demonstration. And you see that the ultrasound technique, it's a handheld device. And now you see the needle again. You go close to the nerve, and then you freeze. That's the way it works. So here, that's a study also from this year from ultrasound freaks. So that's very interesting. And you will see the video immediately, but I just want to show you that. This is an artifact from the catheter they use. Here, this black thing, what you see or don't see is the ice ball, the frozen part of the device. And here, if you don't do anything, you see the intercostal space. Here's the needle coming, and here's where the nerve lives, where you want to go to. You see the ice ball. Now you go away a little bit, and then you see the ice ball while you freeze it. Again, I think you have to calculate for every rib 3 to 4 minutes. And I think this is a technique we could use in the ICU, in the PACU. You need some time, and the patient should be pain relieved to go through this. So what I've saw so far as a recipe is to do a block, anesthetize the patient, and then do the cryoneurolysis. So what my idea of pain management in 2023 would be that we identify patients with a score, stratify treatment and admission based on score, call the acute pain service early for a pain consultant. That means for me not only paying a catheter, epidural, or serratus plain block, but also what are ideas we have from anesthesia. The acute pain service, I hope, will, if it's possible, use non-opioids, catheter technique we just described, and if that's not possible, lidocaine, and in the future, a percutaneous cryoablation, probably in combination with rib fracture stabilization. The two studies below are doing exactly that. So my conclusion, and I'm relatively on time, it's I would like to update the rib fracture protocol from the ED to ICU. I think we should aim to create a flowchart for pain management, especially using of non-opioids, regional and cryo probably. We should get better in prospectively collecting data. Sometimes I think it's just coding, so we can't find the patient, but to find a way that we really can see where we are, what are our failure rates, and how good are we really? And to make life easier, I think it's always good to create order sets in Epic. That would be my last slide. And I'm happy to answer questions.
So Holger, what are the remaining barriers to getting the cryoanalgesia, the local one, implemented here, do you think?
I think the first and biggest problem is nobody knows how billing works. And from a European point of view, I can't understand it, but it's what it is. And I asked the people I think can make it happen to go through the channels. There are meetings of groups where new techniques are discussed. But the bottom line is it's about billing. And then if this would be, other hospitals do this, obviously, but if this would be solved, I think it's a question of training and find patients or patient selection to start.
Can I have
So
a,
how does the group think, or what does the group think about implementing this? I guess is the
Sorry,
other question.
Sorry,
Is
once
this
again,
something- What does the group think about bringing this technology in? I mean, I'd be excited about it, especially for a lot of rib fractures that are kind of below the kind of level of plating, but still have a great deal of pain.
anybody has an opinion about that besides me?
I mean, I think Kelly Gerba passed on a message about, is it approved?
Sure.
Can you hear me? Is the device?
Sorry, has a hospital approved using it? No, this is not, so it's not approved for the hospital, sorry, no.
That's
Dr.
something-
Gillen and Dr. Kangaga told me that they will bring it up in the appropriate meeting. I haven't heard back.
Hospital device committee, whatever, as a.
Could you
technology.
speak louder? I can't hear you.
I think it's my computer. Can you hear me?
It's really distant, but we can hear you.
So we can't use things that haven't been approved by the hospital device committee. Is my understanding.
So Holger, she's saying that if it's not approved, we can't use it. So
That's
I think-
correct.
going back to your point with Yvonne and Jason about how to have to get this approved first before we can use it.
Yes, and and I think we need main key holders from probably anesthesia, ACCS, and probably ICU. If we say we all want it, then I think they should at least discuss it. For the rest, I think there's nothing more than at least I can do. And I'm a strong supporter and I will support it in the future. But from my experience with BANs, it will take some time and we should do it. Perseverance is key. But the other items I mentioned, I think is something we can do. We can at least explore, can we give more non-opioids? I showed you some data. The question is, how often are we really doing an epidural or we don't do it? I don't know because the data are not conclusive to me. And with these techniques I mentioned, it's possible to do it, I think, in anticoagulated patients, even in the US. And you can do it in patients we can't flip around and mention. So I think we have opportunities to improve very quickly. And I personally would say, let's don't forget the cryo, but this will take months, in my humble opinion. Okay, for you, it shouldn't, that we say if we wait for cryo, why are we not at least exploring from the acute pain service to do ESPs if no epidural is possible? Or we just offer the service and offer new techniques. We are not as bound as we are with contraindications for an epidural.
People from the pain service want to weigh in. Gerba is saying we do offer ESPs, serratus, etc. if an epidural is indicated, though this is fairly new to us too.
Yeah,
So
what I mean with that, we can offer that, and I think we should. But then I think it's the advantage of a really comprehensive protocol you bring together. And it's not rocket science in the sense because others did it. But obviously, if our surgical colleagues only know thoracic epidural, they can only ask us to place an epidural. So I think that's what I meant with let's get consulted, and then we say, for this patient, we think this and this is the best. And if we work on such a protocol together, it's all stated there. If you have time, you can read it. If you don't have time, you just want to get the things done, you follow some flow chart we come up with.
Well, I think it definitely shows us that we have work to do and we can do a better job than what we have currently.
I think so too, and I'm more than happy to help. But one thing I've learned, we really should work all together on that.
Well, it's going to take a lot of pressure to get some of this stuff approved, and that's going to speed things up. So especially from the cryo side, if you know, our people will go at it, if anyone else can go at it, you know, from the surgery side, you know, and say that, yeah, this is an issue, it may help. And I think, you know, we need to attack it like that. And I think you're right. We also just need to address our protocols and come up with more extensive protocols that address more things, work with the pain service more, help with getting more experience with all these things. So.
Yeah, I think that this would, at the end of the day, all these ideas just make patient care better.
Any other comments, questions, anything else people want to add?
Happy to join in whatever. Sorry you can't hear me. I put some stuff in the chat.
Perfect. Holger, it sounds like you have the pain services ear, so sure we can make it happen.
Now, what I think what the next step could be is sit together, or I'm old-fashioned, or have a Zoom meeting, and just or I could come up with a draft, and we just can see also obviously with the colleagues from the ED and ACCS how we can work on that, how we get this first draft more medical content, and that treatment is easier and hopefully better at the end of the day.
So is our next step to set up a follow-up meeting with whoever is interested in participating and writing that draft?
Yes, if somebody would help me, because I can write a draft, but then it's just my idea that's biased. So if you or somebody from the acute pain service will join me, probably some surgeon, great.
You know, I do know Mark has a invested interest in how we treat rib fractures. So
I don't want to push him, but I would take him.
Well, he got hit by a train.
Yeah, no, I'm interested. We have 2 cases on for tomorrow. I'm doing a non-union. We also have a lady who fractured all of her ribs as part of a MVC and splenic rupture. So we have these folks coming in all the time. Not everybody is necessarily platable though, and I think.
I think we lost him.
Yeah, so I would be really interested. I personally can't see how many people are there, but are there any other comments on this topic?
Dan Fernandez just posted. Yeah, hopefully if there is a better protocol, it'll be much easier to navigate.
I can ask Dan if he wants to help me. Probably to get it going, I could say I start with our folks from anesthesia and then I just send it around to ACCS, ED, who's interested, just to get it moving.
But I think if we get something down on paper and send it around, that's the easiest way.
Yeah.
By far. There you go.
And I will also send an email again. I don't know when the next meeting is. I think Dan knows when all the meetings are, Dan Fernandez, but I don't know. And for me, it's always way too long.
I think the next ACCS service line meeting is next month, but the discussion time for something like this would probably be about 5 minutes. Given all stuff that's usually discussed in those meetings. But it's still worth bringing up.
Yeah, probably we should at least bring it on the table so nobody can say we never heard about this. And yeah, I will try to set up something this week and send it around, and then we see if something's coming back. And it's my experience that such a multidisciplinary, in theory, also interprofessional protocol only works if really there is buy-in from everybody with during creating and then living the protocol later on.
All right.
Do you have anyone
It's
from
nothing
the ED
else
on
coming
call?
up.
What? Someone was saying something.
Sorry,
Oh.
Kate. Was there anyone from ED on this call?
Let me go through the participants. I do not see anyone from ED right now.
Okay, well, I guess Holger and I and whoever else is interested can try writing a draft, and then probably they need to be roped in pretty quickly too.
That's fine.
Yeah, we can ask him about the femur fracture protocol too.
Yeah, this is a different story. That I don't want to talk about this today.
Fair enough. All right. Well, with that, thank you all for coming. Next month, Patrick Kraft, one of our surgical fellows for ACCS, is going to be talking. He has not given me a topic yet, so I will send out the invite at some point soon. And yeah, thank you all. If you have any other ideas, I'm still trying to fill up next year. So please contact me if you have ideas for a talk or want to talk. That would be even better. But yeah, thank you for all of that, Holger, and looking forward to a developed protocol.
Yeah, we'll do that. Thanks.
All right. Thanks, guys.